Next talk is going to be given by Pan Shuang Jun, and it's entitled MVD and Internal Neurolysis for TN.
Dear Chairman of the conference, experts, professors, good afternoon. My name is Shuang Jun Pan. I'm from the Department of Neurosurgery, Taizhou Hospital of Zhejiang University. It's my pleasure to attending the conference and make a speech. Now let me start my report. Title is MVD with internal neurolysis for trigeminal neurology. As we all know, TN is a pain syndrome collected by recurrence episode of lancinating facial pain. The first line therapy for treatment is medical management. However, many patients may require surgery because of refractory syndrome or intolerable side effects from medicine. Microvascular decompilation was the first surgical treatment for TN. When an offending facial can be identified, that is causing neurofacial compilation. However, patients without neurofacial compilation can either develop TN or recurrence after MVD. Nearly 10 to 20% of the patients with TN will not have neurofacial compilation. As some reported, 29.9% of these with TN type 1 and 18.4% of these with type 2 have no neurofacial compilation. In addition, patients who failures and less severe arterial compilation have been shown to have reduced effect after MVD. Internal neurolysis is a surgical technique used to separate the vesicle of the trigeminal nerve and might be a good option for patients with trigeminal neuralgia, but without vascular compilation. To explore the clinical efficacy and safety of the microvascular decompilation combined with internal neurolysis in the treatment of TN without certain neurofacial compilation. We use the clinical data of the TN patients without certain neurofacial compilation who undergone MVD with IN in neurosurgery department of Taizhou Hospital from May 2019 to December 2021 were respectively studied. Surgery produced. During operation, the internal auditory canal, facial nerve, and pituitary fan, and the surrounding important structures must be protected. For the uncertain type of responsible vessels, that is, the suspicious contact between fascias and nerve, the possibility of unsatisfactory postoperative result after simple MVD was predicted. MVD with IN was used then. We use 8 to 5 mm of the TN coming from the brain stem. A self-made trigeminal nerve coming knife was used to come and separate the longitudinal from the proximal end to the distal end, according to the distribution type of the trigeminal neuralgia, and the position of coming was roughly determined. and the calming was 4 to 10 levels, depending on the situation. As we all see, it's a trigeminal nerve. So this we think is less certain responsible facial. This is a picture under microscope. This is before RN. This calming knife. During the internal neurolysis, the longitudinal calming of the trigeminal nerve root. This is the picture after internal neurolysis. And MVD combined with internal neurolysis. The neurological institute pain intensive scale and hypothesis scale were used to determine the outcomes. Results. The average follow-up was 17 months, range from 6 to 36 months. The post-operative outcome show a BNI pain intensity scale score of 1 for 88.9% with excellent control, and level 2 for 11.1% with good control. No medicine required, no days case, no recurrence. The post-operative short-term complication including facial numbness, oral habits, headache, fatigue, and occipital neglect. All post-operative complications successful recovered during hospitalization, except facial numbness. The overall BNI SHA score post-operative was level 1 for 27.8%. That means no facial numbness. Level 2 for 44.4%. This means mild facial numbness, that is not bothersome. And level 3 for 27.8%. The pathogeneity of TN is color not clear. Also, most scholars believe that channel nerve IEC may be the cause. So MVD alone is not effective in patients with unclear responsible facials or with venous compilation that cannot be decompressed. As reported, venous compilation decreased the pain control rate compared with arterial compilation with BNI-PS score, one rate of 8.1% and 14.3% at 1 and 15 years. Also, most patients who undergo RN will not have NVC. The potential for adding RN to treat patients with milder NVC with regular pain could be a promising option. The most common complication of MVD combined with RN is numbness. Facial numbness occurs mainly because myelin sheaths and some axons of nerve fibers were destroyed during the process of RN. Most of the axons can be retained as the track for remyelination, and myelin can regenerate and restore nerve along the axons. This mild injury lasts for action because of the self-repair of the nerve. So we think MVD with internal neurolysis has shown efficacy in treating trigeminal neglect in selected patients. Completions were limited in journal, but require further studies. This is the new hospital of a new building of a hospital. Welcome to visit our hospital. Thank you.
Thank you, Pan. Any questions for Dr. Shuang Jun? Moji, can Moji have a microphone, please? Question from Dr. Hodai.
Thank you very much. You quoted a rate of 61% of oral herpes after your internal neurolysis. Can you talk about that a bit? That seems very high.
I'm sorry, I beg your pardon, sorry.
Oh, you're muted.
Maybe if you have the slide with the complications of neurolysis.
Thank you for your advice. I'm sorry, maybe I can discuss it after the meeting because I didn't catch your word. Sorry.
Sure, of course.
Okay.
Yeah, we can do it by email.
Yeah, you betcha. Thank you so much, Pan. The next talk,